Okay, it's 12:03, so thank you everyone for signing on today on a Monday at noontime Eastern. Our goal is actually to expand our subscription so that we can reach out to more people. In addition, these rounds are now being archived on the YouTube video channel, which is called SMH Cardio, all in one word. So for those of you who may missed it or either one time or this is difficult for you during the work hours, you can always go to the YouTube video and look at the video and look at the lecture again. Today we have a PGY6, which is one of our cardiology residents, Dr. Ahmed Alabbasi. He's the chief cardiology resident of St. Michael's Hospital. He's going to talk to us about a review of aortic coarctation, which is a narrow escape. So without further ado, please, Dr. Alabbasi.
Thank you very much, Dr. Chow. Thank you for the introduction. For this topic, I decided to talk about aortic coarctation, which is a disorder that we may not see very frequently in the adult world, but we are seeing them more frequently nowadays, especially post-repair and in patients with recoarctation. So I did want to touch on this subject, go through kind of the natural history and the definition and different imaging modalities, and then subsequently into the management strategies and review the AHA and CCS guidelines for management of aortic coarctation. So to start, the coarctation of the aorta is essentially narrowing that occurs in the descending aorta. The most common location for this is just at the aortic isthmus, and it is usually distal to the left subclavian artery. So we see this over here. In critical coarctation, usually the narrowing is quite severe, and this would cause this would reduce blood flow through this very narrowed orifice. And if you have a critical coarctation, especially in the pediatric population, usually the flow to the descending aorta would be dependent on such a patent ductus arteriosus. And when the PDA closes, then usually neonates in the pediatric population with critical coarctation, they usually develop heart failure or shock. This accounts for around 4 to 6% of all congenital heart defects, and it usually is a prevalence of around 4 per 10,000 live births. It does occur more commonly in males, so around 59% versus 41% than in females. The pathophysiology, when you look at kind of the embryology of it all, there's multiple hypotheses, but the most thought of hypothesis is that there's usually abnormal migration of the ductal smooth muscle cells into this area, which is usually at the aortic isthmus, which causes this narrowing. And you can have it either as a distinct obstruction, such as in this picture, or you can get tubular hypoplasia of the transverse or aorta, or you can even have both. And this, we'll talk about later, does have some implications on the mode in which you would tackle this with regards to either transcatheter or surgical repair. Aortic coarctation does occur commonly in association with other disorders, either in association with syndromes or in association with other congenital heart defects. So the most common one that is associated with coarctation is Turner syndrome. So up to 30% of Turner syndrome patients do have aortic coarctation, which just goes to show how important it is to image the aorta, at least initially in a patient with Turner syndrome, to ensure there's no coexistent aortopathy or aortic coarctation. But other than that, there are associated cardiac lesions, and also less than 25% of patients with coarct have isolated coarctation. So the majority actually do have associated cardiac congenital diseases. So around 40 to 50% have a bicuspid aortic valve, which also emphasizes the importance of aortic imaging in patients with bicuspid aortic valve. Around 14 have aortic arch hypoplasia. 13% have a ventricular septal defect, and it can occur in the setting of a Schoen complex, which is a complex of left-sided obstructive lesions. And I usually like to remember it through the mnemonic PASS, where the blood has to pass through four stenotic lesions on the left side, or obstructive lesions. So you have P for a parachute mitral valve, A for aortic regurgitation, and the two S's is for a supravalvular mitral ring and a subaortic stenosis. So it does occur in the setting of this of a Schoen complex as well. The natural history is that usually the average age of survival with unoperated coarct was approximately 35 years, and it approaches a staggering 75% mortality by the age of 46. And usually in unoperated patients, or in those that are operated on later in life, you can get systemic hypertension, you can get accelerated coronary artery disease, you can get stroke, and obviously due to this elevated blood pressure and aortic changes, there is a propensity, of course, for aortic dissection, and due to the high LV afterload, obviously you can get heart failure. So causes of death would be heart failure, aortic rupture, dissection. There may be an endocarditis or an endarteritis, intracerebral hemorrhage, as we'll talk about later, as there is an association with intracerebral aneurysms in these patients, and myocardial infarction, be it due to accelerated coronary artery disease or hypertension and the setting of high LV afterload. I thought this was interesting we do see these patients quite commonly in the clinical setting, be it, the first presentation or later on in life after a surgical repair or a recoarctation. So it would be important for us to recognize these signs on physical examination. The first of which is usually you get reduced systolic blood pressure in the lower extremities when you're comparing it with the upper extremities. So you get systolic hypertension in the upper extremities, and you can even get unobtainable blood pressure in the lower extremities. So this usually manifests as delayed femoral pulses or diminished femoral pulses. So you'll get a brachiofemoral delay. And the site of origin of the left subclavian may actually affect the severity of this of the radiofemoral delay or the pulse findings. The first and second heart sounds are usually normal. If there is pulmonary hypertension, usually later on in the disease course, you may hear a loud P2. If there is a bicuspid aortic valve, which usually occurs in 40 to 50% of patients, you may hear an ejection systolic click and a systolic ejection murmur at the apex or the left sternal border. And then you may be able to hear a systolic murmur beyond the second heart sound, which would be indicative of the turbulent flow across the narrow coarctation area. If there is a development of large collateral vessels in the setting of this stenosis, you may hear a continuous murmur throughout these arteries. And you can also hear murmurs of other congenital heart defects. So PDA may present with a continuous kind of machinery-like murmur, VSD or aortic stenosis in the setting of a bicuspid aortic valve. And if you have any of these syndromes, such as Turner syndrome, you may be able to see some of the phenotypic features associated with this disorder. We'll start off with maybe just the basic investigation. So ECG may vary and may be normal. And if there is left ventricular hypertrophy, you may see some increased voltage and STT wave changes in the left precordial leads. The chest X-ray may show us some rib notching, which would be indicative of collateral vessel formation. So notching of the usually the posterior 1/3 of the ribs due to erosion by large collateral vessels, as you can see here on this chest X-ray. Usually, this becomes apparent in the adolescent, pediatric to adolescent population. And you may be able to see an indentation in the aortic wall at the site of coarctation, which is a figure 3 sign, which shows your pre-coarctation and your post-coarctation dilatation. So this is on chest X-ray. Obviously, these may not be present on all patients, but this, if they are present, they would be indicative of a coarctation. Echocardiography can be used and is used predominantly, I would say, in the pediatric adolescent population. We do use it in the adult population as well, but in the adult population, it's recommended to do either CTA or MRA to better characterize this. It can detect any associated cardiac defects. So if there's any associated aortic hypoplasia, or any associated cardiac lesions, it could be able to detect that. Usually we look at the suprasternal long axis view, where we're able to see a discrete area of narrowing called the posterior shelf. And this is usually within the lumen of the proximal descending thoracic aorta. And obviously, you'll be able to see turbulence across that with color, and pulse wave Doppler echocardiogram may be able to demonstrate some forward diastolic flow as well. The CW Doppler may be able to estimate the severity by looking at the maximal flow velocity across that area, and that will give you the pressure gradient. And you may also be able to get a surrogate of severity by calculating the ratio of the maximal velocity across the coarctation to the, you look at the ratio of that to the peak velocity in the abdominal aorta. We should note that if there are collateral vessels, this may further diminish the gradient across the coarctation, so would be less than expected given the degree of the stenosis that you may see on the echo. So we don't usually look at the peak gradient when it comes to indications for intervention. I thought these were interesting. So in figure A, this would be your suprasternal transthoracic echo image, which demonstrates what we see here with an arrow, a severe narrowing in the descending thoracic aorta. This is a color flow demonstrating marked flow acceleration across the narrowed site over here. This is figure C, which essentially shows a peristernal short axis view across the aortic valve, which shows an associated bicuspid aortic valve here, frequently seen in patients with coarctation. D is a pulse wave Doppler here of the abdominal aorta, and we see that there is a low antegrade systolic flow, but you also see persistent flow in diastole, which is suggestive of turbulence there. And then we see here a continuous wave Doppler demonstrating quite a large gradient or severe obstruction at the site of coarctation. Your peak systolic gradient of 65 and a mean of around 32 here. So you do see some persistent forward flow occurring during diastole as well, consistent with your persistent pressure gradients across this coarctation. MRI or CTA is looked at more frequently in these patients, and it's able to clearly define the location, the severity, and even look at the formation of collateral vessels. You may be able to identify patients who have significant gradients across this, which may provide you some anatomic data prior to the intervention. If you have patients with a coarctation of the aorta, even if it's repaired or unrepaired, it's recommended through the AHA and the CCS guidelines, both that CMR or CTA be done as either an initial or follow-up imaging of the aorta, even post repair. It may be also able to detect some other cardiac abnormalities as well. CMR would be preferred over CTA because of the lifetime radiation burden, but if the CMR is contraindicated for whatever reason, then you may use a CTA. The AHA does mention a class 2B recommendation for MRA of the cranial, so a cranial MRA, because there is a strong association. Up to 10 to 20% of patients with coarctation do have intracranial aneurysms, and so that must be something that you should consider when you're assessing these patients. Cardiac catheterization could also be done by measuring kind of the LV and then pull back into the aorta and going through the stenotic area and measuring the pressure gradient between that. And maybe inaccurate if patients is taking multiple antihypertensive medication or is under sedation. So just to note that cardiac hemodynamics may be inaccurate in this setting. With regards to the MRI, and there's an image after that with the long axis candy cane view. So this would further delineate the aortic anatomy, how obstructed the aorta is, and if there's any any aortic valvular dysfunction. The Cineas SFP is the gold standard for your LV size or LV function, and you're looking at the black blood FSE, which would be useful for evaluating the entire aorta, particularly since it is affected less by any metallic artifacts. So it would be best in the setting of post repair. And phase contrast imaging can then characterize the flow ratio between the descending to the ascending aorta and to be able to estimate the pressure gradient. On the right here, we see this is a three-dimensional MRA with aortic coarctation. And what we see here very nicely is several of these tortuous collateral vessels that have formed in the setting of this severe narrowing, just distal to the left subclavian, and dilated internal mammary arteries as well. So here we see a few MRI images that quite nicely demonstrate coarctation. So this is a pre-procedural one, a black blood. This is an oblique image, sagittal view, which shows a discrete tight coarctation just at the aortic isthmus. Over here, in this image, we see a 3D CTA, so contrast and as CT angiogram, so showing a bare metal stent, as we see here in the aorta. It looks like it's at least mildly narrowed, and it kind of partially overlies the left subclavian region. And this points here to what is probably a subtle pseudoaneurysm at the distal end of the stent here. This image here is a contrast-enhanced 3D image of an MRA showing some aortic arch hypoplasia and what appears to be a coarctation with a jump over here. Which with a bypass graft posteriorly. So this is post-surgical repair. And this one here, we see an MRA showing a previous patch angioplasty and what looks like a large pseudoaneurysm just at the site. So it's very useful for both pre-op assessment and post-procedural assessment. So what is the definition of a significant coarctation? So this is from your AHA and the CCS guidelines. So this is a resting peak-to-peak gradient of more than 20 between your upper extremities and the lower extremities, or a mean Doppler systolic gradient of more than 20. And then you can also get it if there's more than 10 millimeters of mercury peak-to-peak gradient in the presence of either decreased LV systolic function or aortic regurgitation. And if you've demonstrated collateral flow either through a CMR, CTA, or another imaging modality, then usually you would expect the gradient to be less pronounced. So it's accepting of a gradient of more than 10 between the upper extremities and the lower extremities, or a Doppler gradient of more than 10. The CCS 2022 guidelines does note that you do need an anatomic evidence of coarctation of aorta, which makes sense. This is typically done by CMR or CTA. The CCS clearly demonstrates, it clearly notes that they would need a more than 50% narrowing of the aorta compared to the diaphragmatic aorta on an MRI. So this just further, highlights the importance of MRI testing in coarctation. I've just put the CCS recommendations here. So who requires treatment? So anyone with a significant native or recurrent. So the guidelines are for native or recoarctation, who have a simultaneous peak-to-peak gradient at catheterization of more than 20 or more than 50% of narrowing on the aorta compared to the diaphragmatic aorta. Should have an intervention if there's concomitant systemic hypertension. So the key here is that these patients should be hypertensive. And if there's native or recurrent, if there's significant or discrete, then they would recommend a repair with a transcatheter stent if it's feasible. But if the coarctation site is long or narrow, or if there is diffuse arch hypoplasia, then it's recommended that there is a surgical approach. The AHA 2018 guidelines note that initial and follow-up imaging with the CMR or CTA is recommended. We should measure resting blood pressure in the upper and the lower extremities in all patients. This is a class 1 recommendation. Class 2A would be for ambulatory blood pressure monitoring, as some of these patients may not be hypertensive in the office, but they may have blood pressure that's elevated at home. So ambulatory blood pressure as a class 2A recommendation. Class 2B would be screening for intracranial aneurysms, as mentioned, as these could be associated with it. And a class 2B would be exercise testing, as you may not have systolic hypertension at rest, but with exercise, these patients may become hypertensive. And so it may be reasonable to do exercise testing to measure their blood pressure. The therapeutic class 1 indication, so surgical repair or catheter stenting for patients with hypertension. So key is that these patients should be hypertensive. Obviously recommended for us to do GDMT as indicated for patients with hypertension and coarced. And you could do balloon angioplasty, may be considered if stent is not feasible and if surgical intervention is not an option due to whatever reason. You could consider doing a balloon angioplasty, but it certainly isn't ideal. I just wanted to touch on this again, as a lot of these patients do have approximately 10% of patients with coarctation do have intracranial aneurysms, and this is as compared to 2 to 3 of the general population. And it is a class 2B recommendation to screen for this at diagnosis. There is some data that shows that intracranial aneurysms are actually uncommon in children with coarced, but as you age, it's possible that there is accelerated hypertension and vascular changes, and that may drive the development of the intracranial aneurysm, but the recommendation is still to screen for it at diagnosis. I wanted to touch on some of the complications of repair. The surgical repair is purely kind of as great at relieving the obstruction, and there's usually a minimum mortality rate of around 1%. You can get certain complications such as paraplegia, especially if you do not have a well-developed collateral circulation, and this may occur in the setting of spinal cord ischemia. There is a high a relatively high prevalence of recoarctation, and it varies in the literature. Anywhere between 7 to 60%, usually is around 10%. And it depends on, the age of surgery and the length of follow-up. And usually uh, usually the appropriateness of the surgical repair for the anatomy is probably the main factor that's involved in the chance of recoarctation, as opposed to transcatheter versus surgical. If a transcatheter repair was done to someone with maybe associated arch hypoplasia or something, then obviously the incidence of recoarctation would be higher. So just how appropriate the repair is to the recoarctation does define how much the chance of recoarctation is. Maybe you can get sometimes a true aneurysm, and this is a well recognized entity, and it can occur between 2 to 27%. Usually that's common after a Dacron patch or aortoplasty, and usually occurs in just at the native aorta, which is opposite to the patch. And you should be checking for this with follow-up CMR or CTA. The CCS does recommend possibly a CMR every 5 years to look for these complications. Late dissection could be present as well, and obviously long-term follow-up after surgical correction may be associated with increased premature CAD and death due to hypertension and other risk factors. So what are some of these surgical options? So you can do an end-to-end anastomosis, where essentially there's excision of the narrowed area and then direct joining of the aorta. A graft interposition, where you would resect the coarcted area and you'd replace it with a synthetic graft. A Dacron patch, which is essentially an incision across this narrowing, and then you would enlarge it with a patch, but is less used now due to the previously mentioned risk of aneurysm. You could do a subclavian flap repair as well, where you would use a subclavian artery flap to enlarge the narrowed segment. And then ascending to descending bypass, which is basically a conduit graft. But this is rarely done. And you should be tailoring this to the anatomy of the patient. If there's associated hypoplasia, etc., this does reduce the risk of recoarctation. But with regards to if the patient has, for example, a bicuspid aortic valve and requires an aortic valve replacement, this CCS does recommend to consider a staged approach. So you can do a stent first if the AVR is not if the aortic valve is not significant, and then subsequently an AVR later. Or you can also do a combined surgical approach if there's diffuse arch hypoplasia.
Budget, so that will be of note, and you touched on that there.
With regards to what factors would favor transcatheter versus surgical approach, because I wondered about this. If you have, obviously, as mentioned, a discrete focal lesion with minimal arch hypoplasia, this would favor transcatheter. A long segment disease where you have associated aortic arch hypoplasia, then this would favor surgical approach. If this is a less tortuous, good access, and large enough vessels to accept the stent, you would favor a transcatheter. If there's any complex arch anatomy, there's tortuosity. If the branch of the arch branches are involved, if there's small vessels, then this would be better handled by surgical. If there's good vascular access, as for example with femoral, or a large vessel diameter, favor transcatheter. And when the patient is young or the patient would grow, then we would favor a surgical approach, as you may need repeated redilatation of the stents in the future as the patient grows. And we did mention the CCS guidelines about balloon dilatation without a stent is not preferred, but there is a risk of intimal tear, and there's a long-term risk of aneurysm formation. So we don't prefer to just balloon it, prefer to keep a stent in there. So these are kind of the main main factors that would favor either a transcatheter or a surgical approach. And when you're looking at the literature, unfortunately, there aren't any randomized controlled trials that go head to head, whether this is transcatheter or surgical approach, which one is better. But there are some observational studies which did include quite a number of patients. So there's a study that was published in JACC in 2011, which compared surgical stent and balloon angioplasty, and this was native coarctation. Did include the adolescents and adult population, but also did include different patient ages. So there was a pediatric inclusion there, and it followed patients up to 5 years, and it found that they both did achieve, both stent and surgical repair did achieve a good reduction in the gradient. The stent group had lower immediate and short-term complications and less hospital stays, obviously, as it's not an open heart procedure, but reintervention rates more common in the balloon angioplasty and stents, as especially if you're putting it in the pediatric population, you do potentially need to resize it and to dilate it in the future. With regards to hypertension, relief was not perfect, and there was persistence of elevated blood pressure in many patients, and we'll get to that in the next slide. This was obviously a large study. I think it was around it was around 350 patients, and there was multiple institutions, so it was around 36 centers. So there may have been some operator institutional preferences there, different patient ages, and it wasn't a randomized controlled trial. There was another study more recently in CIRC in 2021, which looked at long-term outcomes of coarctation stents. So this didn't look at surgical repair, so it was only focused on stents, which was adults and older children with either native or recoarctation. And it said that stents were effective at maintaining relief. A lot of patients did require some reinterventions, but fewer. And blood pressure improvements did occur, but there was residual hypertension. And there was a 2024 study which looked at a comparative analysis. This was an observational study between surgical and endovascular repair, which basically compared open surgical versus endovascular with their balloon or stent. And this was a several years follow-up. Both of them were effective at relieving the stenosis. Surgical repair tend to have more durable outcomes, and of course, in some anatomical situations, it would be better if there's associated tortuosity or hyperplasia. The endovascular gives you obviously a less shorter hospital stay and a faster recovery, and there is a higher chance of reintervention in patients with endovascular or stent procedures, especially if they were younger or they had certain anatomies. I wanted to touch on this as you'd think that hypertension would completely resolve in these patients, but it actually only resolves in 50% of patients, and then it may actually occur later in life, especially if there's more, if it's been done at an older age. And obviously, the differential for this will remain essential hypertension, but it may actually be related to residual arch hypoplasia, and it may actually be residual aortopathy or residual vascular changes, which would increase your renin and aldosterone system and catecholamine activities. So you actually may have residual hypertension in a lot of these patients, despite patients who have, despite fixing the actual stenosis. You may actually get late cerebrovascular events, and as mentioned, endocarditis or endarteritis. So nearing the end, I just wanted to summarize a few of these things that we just learned. So Coarctation would be, it's a congenital narrowing of the descending aorta, usually is juxtaductal or at the isthmus. It occurs more commonly in males than females, and is 4 to 6% of congenital heart defects. Hallmarks would be upper limb hypertension and lower limb hypotension, and you may feel a brachial or radiofemoral delay. You can hear an intrascapular systolic murmur due to a high flow across the narrowed valve, and you can hear a continuous murmur from collaterals, and it can be associated with multiple congenital heart defects such as bicuspid aortic valve, aortic arch hypoplasia, Turner syndrome. Echo to define narrowing and gradient, and the best test would be CMR slash CTA to define anatomy, the presence of collaterals, and is the best for follow-up imaging to monitor for complications such as recoarctation or such as aneurysm formation. And you do need to screen adults for intracranial aneurysms, which occur maybe in around 10%. If untreated, you can get early mortality, and you can get hypertension, premature CAD, stroke, aortic dissection, heart failure, the development of aneurysm, either before so pre-coarctation or post-coarctation. And with regards to management, is indicated if there's hypertension or if the gradient, and if there's a significant upper extremity to lower extremity peak-to-peak gradient of more than 20 or more than 10 in the setting of LV dysfunction, AR, or in the presence of collaterals. And you do need more than 50% narrowing of the coarctation as compared to the diaphragmatic aorta. Surgery would be preferred with complex or long segment diseases. In the younger patients, arch hypoplasia, and if there's any associated lesions, surgical would be more recommended. Transcatheter with a stent would be favored more than a balloon, but is favored mostly in the adult if there's a discrete focal coarctation. Surgical mortality is low, but recoarctation occurs up to 10%, depending on anatomy. And then stent is durable in the adults, but you do require surveillance with a CMR, CTA, usually every 5 years. You may have persistence of your hypertension despite repair due to vascular changes and upregulation of your renin-angiotensin system and catecholamines. So usually lifelong blood pressure control is needed. These are my references. I'm happy to take any questions. Thank you very much for listening.
Thank you, Dr. Alabbasi, for reviewing this very important topic, because this is often in the exam. So it's useful for the trainees as well to know about this. It is one of these things that we always think about when someone developed hypertension, especially in the unusual age range, especially when they're young. So definitely part of our differential diagnosis. So from my perspective, I have a question. How useful is physical exam for this? Because often we talked about, measuring blood pressure differences between the arm and etc. So what do you think? Should we do bilateral blood pressure on all patients with hypertension to rule this out? And if we do that, how effective are we actually ruling that out?
So I think what the main thing would be is especially if you have a younger patient with a hypertension, lack of family history, then you would definitely, I think, it would be warranted to do blood pressure in the upper extremities and the lower extremities, especially in the setting of a systolic murmur or something. Whether it's there's a direct proportionality with regards to diagnosis and someone who has unequal blood pressure, upper and lower extremity difference, I'm not sure, but I would say physical examination would be, at least when you're first seeing them in clinic, would be quite important, especially in someone who's young with hypertension, and especially if there's a finding of if you have a high pretest probability, such as this patient having bicuspid aortic disease or other cardiac congenital defects, and someone with Turner syndrome, etc. I think I would definitely, think physical examination would be important.
Yep, that's very helpful. One of the tricks I use is actually looking at the echo, because we often, as part of our workup for someone who has hypertension, we look for airway volume, airway mass, and also in the echo we do a suprasternal notch view to look at the aorta, and that's a good screen for someone who may or may not have coarctation, at least in the more proximal segment.
Yeah, so I think I have an image of that.
That's right, that one, yeah.
Yeah.
So we look for gradient more than like a peak of 20, for example, and then we'll go from there.
Yeah.
Cool. Okay. Any other questions from our audience? So there are about close to 20 participants online as well.
I see Kim is, yeah.
Yeah, I had a quick question, Ahmed. Great rounds, great review. This association with coronary artery disease. Where did your reading take with that? Do you know of any data showing if it is an independent risk factor, or is it all driven by hypertension and other things? Because this has been quite a really important point in the sort of coarct history. And there was a staff at Sunnybrook who published a circulation paper on it. So
yeah, so I think, well, there's two things with coronary artery disease and coarctation. The coarctation may be associated with coronary artery anomalies. So that's another that's another thing that you need to put in mind with patients with coarc. But there is an accelerated coronary artery arteriosclerosis in the setting of coarctation, in the setting of high LV afterload, hypertension, and vascular remodeling and changes. So I would say probably mostly related to that. I'm not aware of any, specific, other than the, associated coronary artery anomalies. I don't know, maybe if Dr. Conley, but if there's any specific association between coarctation itself and atherosclerosis of the coronary arteries, other than you'd think that there's association with hypertension and vascular remodeling in that setting.
yeah, there was a lot of sort of anecdotal retrospective evidence in the past suggesting that maybe coarct modified endothelial function, which then would predispose, independent of all the other traditional risk factors. We don't really know is the bottom line, but Edan Roifman actually did a very nice study with Ariane Morelli when looking at the Quebec database and did sort of age sex match controls, and once they counted for traditional risk factors, within the the limits of that style of study, there was no particular excess risk, and it was all driven by exactly what you've suggested, sort of hypertension and ongoing features. So I think for the most part, the literature feels though that it's not an independent, but it's all through the hypertension. But 10, 15 years ago, this was actually a big question for the adult congenital guys. What do we need to do? How do we need to do it? So I think we need probably a few more studies because it was retrospective, but at least you can ask Edan when you're at Sunnybrook about it, right? Because it was a circ paper, so it was it's the large, I think it was like 1,200 people. It was a very large data set, so probably unlikely to be replicated, but great rounds. Thanks.
Thank you.
Thank you, Kim. Any other questions from the audience?
I have one, Chi-Ming. Bob Howard.
Please go ahead, Dr. Howard.
Hi, Emmett. Great rounds. Thanks. My question relates to the kids who at a young age are diagnosed and have, say, a surgical repair. What's the likelihood in adulthood that they're going to be restenosed, given that the repair doesn't grow with the kids, sort of thing?
Yeah, so I think the main the recoarctation in the literature, it varies quite frequently. I've seen some studies quoting up to 40%, as low as 10% in some cases. The main thing I think that would dictate if you have a recoarctation is was the appropriateness of the actual repair to the anatomy. itself. So if if someone had a surgical repair, I'm not sure about the exact details of which, but for if there's associated arch hypoplasia or something like that, and it was kind of maybe an inappropriate technique, then that would be an increased risk for recoarctation. But usually somewhere between 7 to 60% is what I found, and I think most of what I was able to find is usually around between 10 to 20%. And obviously, the younger, I guess, you are as a patient's age, there's an increased risk for that to happen.
Great, very useful review, and I think it will be worth for cardiology residents to review this in the archives, especially when they're preparing for the exam. I must say, I studied this during my training period, and keep looking for it for the rest of my career. They're actually not that many.
Yeah,
I think each of us has a handful of them in our practice. Handful.
Yeah. It's a pretty high yield topic, I think, even for the boards. I mean, I'm studying for the boards now, coming up in a few months, and this is very frequently tested. So it's a good review for me as well.
Yeah. Well, there's a number of things that we learned during our training. They're not that common. Pericarditis is another one, or constriction rather, and they're not that common. But then unless you look for them, you're going to miss them. So I think that's part of being a specialist in doing what we do. So that's great. So thank you so much for reviewing this topic, which is very essential and very core to our knowledge set. Okay, so barring none other questions or concern, then we finish. But just quickly, our goal is continue to expand our participation in the cardiology rounds. I'm taking over from Dr. Yan, who has done this for 15 years, thanks to Dr. Yan's major contribution and leadership over the last 15 years. But moving forward, the goal is to try to find out, a number of things in the modern time, so as to say, or contemporary times. That is this timing good? Is Monday at noon good for everyone? To increase in viewership, and also what kind of topics and what kind of formats. So love to hear from you. If you have any interesting idea or thoughts, please email me, and then we can try to improve our rounds and expand our coverage, I guess, or expansion. And also we have a YouTube channel that I mentioned in the beginning. So please like, subscribe, tell your friends about it. It's SMH Cardio, all in one word. So I keep working on, putting these rounds together in a very easily digestible format on the YouTube afterwards. So thank you.